All right, welcome. If you're here, just know that you do have to subscribe to send any chats, any questions, things like that. Mainly because we want to cut down on any potential for trolls or bots or spam, things like that, especially because we're talking about such a sensitive topic. So, today we're talking about clinical and ethical practices for protecting autistic clients. And so, you might have a question of like, how did we get here and why are we talking about this? And a quick intro from me, because I don't often do this. So, I am Dana Sia, pronouns she, they. I'm a licensed mental health professional. I'm not your licensed mental health professional, but I do help folks as well with like consulting and supervision, so encourage you outside of this to go and get your own consultation and supervision if you are a mental health professional. If you're a client, I encourage you to talk to your own mental health professional or find one who can help you navigate this space. I do autism assessments and work with a lot of folks who are autistic. So, this recent discussion around an autism registry has been very concerning for me, very concerning for the folks that I work with and my colleagues. And that is why I wanted to bring this video here today. Usually, I have very polished trainings with PowerPoints, but today we're just pulling it together so we can talk about what is going on in the here and now. So, how did we get here? The Health and Human Services Secretary, Robert F. Kennedy Jr., has been talking a bit for a while now about doing research on autism, as well as just making general inaccurate statements about autistic people's worth. And the general comments around doing research on autism was by some very welcomed and by some very concerning. And what took it to that next level, I think, is on April 21st in a Council of Councils meeting, the National Institutes of Health, the NIH director, Dr. Jay Bhattacharya, he stated that the NIH would be leveraging large scale data resources, those that are available through the federal government already. But he also mentioned pulling in data from the private sector. And the quote was to create a real world data platform. So, this data platform has been described as a registry of sorts where it would compile data on autistic folks. He did note that this was going to be, quote, a robust and secure computational data platform for chronic disease and autism research. For me, that is a little interesting that he's combined chronic disease and autism, not only because some of the inaccurate statements have conflated the two, chronic disease and autism, but because many autistic folks also have chronic diseases. So it brings up a question for me about what would this potential platform include in it if he's being very broad in his statement about chronic disease and autism. What other diagnoses are we talking about, right? What's going to fall under that broad category? So, understandably so, there's been a lot of outcry, a lot of concerns about this registry or platform. And so on April 24th, we saw multiple journalists reporting that they had received statements back from Health and Human Services noting that they would actually not be creating a platform or a registry. And I think it's a key takeaway here to know that there's no formal statement yet from either the HHS or the NIH about whether or not they're going to move forward with this platform or registry. So just keep that in mind as we move forward. I think it's been a bit of a roller coaster, as many things are here recently. That there was concern around the platform, the registry, and then there was a bit of relief once we saw the statements that they weren't going to create it. But for me, there's just a big question mark because nothing formally has been noted. So, what data sources would this platform or registry pull from? And it is noted that it would include data that's available for other research programs within the NIH already. It would include claims data for Medicare, Medicaid. It would include electronic health record data with participating institutions, which I will talk about here in a second. pharmacy chains, as well as health organizations like the VA, the Defense Health Agency, the Indian Health Services. And kind of outside the scope of all of that, he also mentioned that information from sensors and wearables like smartwatches and trackers would be included in that data. So the direct quote is that he noted they would be looking at, quote, detailed diagnostic information. And this would be found within labs, imaging, genomics, and claims and billing data. So that's concerning to us as mental health providers because we don't want to unwittingly release this information into a database or a registry that we don't know anything about. The next question then being, are there any protections put into place or that would be put into place with the platform or registry? So Dr. Bhattacharya mentioned several times in the transcript, which I can link below later, that the platform would be secure. This includes statements such as, quote, state of the art protections that would be used to make sure that the linkages of data would in no way threaten the confidentiality of patients. Those state of the art protections were not described, they weren't explained. It was just noted that state of the art protections would be put into place. He also noted that researchers would be able to do their own work on the platform, but they would not be able to download the data themselves, meaning the researchers would be able to do work while they're in the system, but they would not be able to take any of the data from the system out of the system. Um, he stressed that, and this was towards the end of what he was saying as he was announcing this. He stressed, quote, harming patients as far as their confidentiality is concerned will not be possible. So is that type of a promise reasonable? And not really, right? Like there's no 100% way to make that claim that it is not possible for their confidentiality to be harmed. We know this through the Vanderbilt University Medical Center, sorry, reverse that. When they had a request from the Tennessee State Attorney Generals for data to follow up on some claims of maybe misuse of insurance for trans and non-binary clients at the medical center who are retreating for gender affirming care. And instead of following essentially HIPAA guidelines and de-identifying the information, or just providing the information that would have been needed to look into those claims of misuse of insurance, they handed over complete medical records for trans and non-binary clients. So that's where the concerns for me overlap. We have examples, clear examples in the past when data should have been de-identified or minimized to decrease the risk of exposure, and someone just didn't do that. Just because there's a law doesn't mean that people are following it, right? I think that's what we often go to is, well, HIPAA's in place and HIPAA is going to protect us, but it doesn't always work out that way. So is that type of promise reasonable? Not really. Keep in mind also that HIPAA does not cover the data that would be in sensors or wearables. So this could be something like a smartwatch, which there are versions of that for even within mental health to track breathing and heart rate, things like that. It can be used with heart monitors, for example. And these things are often given by or prescribed by medical professionals, but none of that data, none of the data that's going into that device, none of the data that's going from the device to the provider is covered by HIPAA. That's important to know. If they're going to include this information, then they're not going to technically have to follow HIPAA guidelines with related to that. So de-identified data or aggregated data also is usually not held to the type of standards, the highest standards of HIPAA. So that would be also something to be concerned about. I think an example of this is with rates of death from suicide. If they are very low or specific in smaller areas, geographical areas, that data is actually not able to be used in research or published because it could easily be linked back to the actual person or people who had died from suicide. So we would need protections like that in place with this. But if they are pulling from data that's already out there, they could make the argument that, well, it's already aggregated, so it doesn't need those protections. Um, he did note, Dr. Bhattacharya did note that the patients rather, their geographical information, like zip codes, could potentially be included in that data. So there are ways if someone really wanted to kind of connect the dots and find specific people, even if the data wasn't intended to be used that way. So I've been talking about 10 minutes straight or so on how we got here and some of the information that I've been able to look into as far as the platform that could potentially be created. It's being called a registry. So if you see that, know that it is being called the Autism Registry. And the reason for that is because there are certain states in the United States of America who do have registries where medical providers are required to report any instances where autism is diagnosed. Each state is completely different. Some of them it's all age ranges, some of them it's only minors, some of them it appears to be close to the time of birth. So every state is different and there's different restrictions. So just be aware of that. But that's where the language came from for the registry. What you might expect from clients on your end as a mental health provider is that clients may be asking where their data is being stored, how it's being stored, where it might be shared, who's sharing it, and how to limit the sharing of the data. So be sure to talk to clients always about how their data is being stored. If you're using an EHR, electronic healthcare record, talk to them about who can get a copy of it. Make sure they understand when you have releases of information, why you're having them sign that, who it's going to, what type of information is going into that. So if you're, for example, maybe connecting with a colleague or another medical provider so that you can give and get information, let them know what type of information might be shared and with whom, those kinds of things. I think from me, when I do that, I also let clients know ahead of time, like, hey, there's this request to coordinate with this other colleague or provider. Are you okay with that? We and then let them know afterwards that we had that discussion. The other key thing is not just on records, but also with diagnosis, because that's really what we're talking about here, right? Is what diagnoses are clients receiving and where are those going? So often we go to insurance if a client is using their health insurance and we are billing their health insurance, whether that as an in-network provider or if we are providing them super bills so they can use their out-of-network benefits. For the most part, that is going to have some sort of diagnosis on it. Let them know what that diagnosis is. I think our field for too long has been a smoke and mirrors type of approach to diagnosis where we are using diagnoses to bill for clients and their health insurance, but we're never telling them what those diagnoses are or coordinating with them to make sure that it's accurate. So that is a huge change that our field needs to make. And I think it's across the medical fields. It's not just with mental health, it's all medical fields. But talk to clients about their diagnosis and how that works with insurance and how that goes on file, things along those lines. You may not know completely how the insurance companies that you're billing or sending those claims to might be using that diagnosis, but look into your contract, talk to representatives at the insurance companies about where that information is going so that you can have a more informed discussion with your clients and encourage them to reach out to. Um, there are other places though that diagnoses could go. So if someone is looking for accommodations, this could include their work or their school, and each place is different. Some places want to know the diagnoses, some places don't. Some places, I'm thinking about a specific school, for example, that I've written some letters to support clients in receiving accommodations at the school, and they require certain proof, if you will, of the diagnosis. Like, how did you come to that diagnosis? So, just be aware of that detailed information that they may be asking for. And then, if any clients are filing for disability, whether that is short term or long term at work, maybe it is FMLA, the um, federal law that we have, or they are applying for more locally disability benefits at the state level. So just talking to them about how those diagnoses go into their file with regards to the different work, school accommodations, disability, and then, of course, the insurance that I mentioned. One that I think we also could forget, if you will, is any sort of potential for a court order or a subpoena for our records. Every state is different, every profession is different, every code of ethics is different. So the language you use may be different. And I'm not a legal advisor, so definitely seek out legal counsel if you do receive a subpoena or a court order, or go ahead and do it now. There are trainings out there, great trainings that will talk to you about how best to respond to court orders or subpoenas, who they come from, if it's a lawyer or a judge, if you're being required to show up in person or send documentation. Talk to clients about the potential for that, of course, and also be prepared yourself if that was to happen. And that is the case for Vanderbilt University Medical Center, was that they had that order from the state, and that was why they released that information. Did they do it correctly or appropriately according to HIPAA? Probably not. I think the argument could be made there, but they were responding to a legal request. I talked a little bit about electronic healthcare records. I think it's important for us to know our EHR's privacy standards. What are their policies? When will they release information? They also are held to legal standards where they may be required or requested of them to release information. So be aware of what that might be, because as much as you might say, I'll never release your information, what if your EHR is ever taken to court for some reason and they have to release it? Again, that we can't 100% note that there is no risk to that data or to confidentiality. The privacy standards, the policy should also be available for clients. I'm sure we just clicked some check boxes or signed our name or whatever it was when we started using the EHR, and the same on the client's end, I'm sure. But it's always helpful to go back and reread it, especially if there have been any updates. I know some of the major EHR platforms have made some updates in recent years that, depend upon how you feel about artificial intelligence and the ways that they're using the data in the EHR, it's a little bit looser on the restrictions than it was previously. Okay, just checking in. I don't see any comments. I'm also keeping an eye on my email to see if anybody sends anything over, because I recognize you may have questions about, like, what to do now. And I think specifically around diagnosis can be a big question. So, if you are doing assessments, should you be diagnosing autism? If you have autistic clients, should you be noting autism as a diagnosis in their record and using that to bill insurance claims? Even if you're not using autism for insurance reasons, should you be noting that in any of their progress notes or treatment plans or anything like that? Um, and then another question that I've seen is, if you've already noted that diagnosis, should you be removing that diagnosis or replacing it with something else? And all of these questions are ethical decisions to be made, right? So I can't give you a just yes or no answer on any of these questions. It really needs to be an ethical decision that you make, and not even by yourself. Get support from colleagues, get support from supervisors, and talk to clients about how you want to navigate that information, the diagnostic information, or even just including those topics in your notes. If you don't have a good ethical decision making process yet, then I highly recommend finding one. There are several out there that have been created by researchers or created by associations. You could create your own. If you're looking for a template, let me know. I have a template. I have a training on ethical decision making, but if you just are wanting a template, a free template to plug in your decision making process, I have that as well. You can use it as a Word document. You can put it in your EHR. It's important to do this process, the ethical decision making process, before you make a decision. It's showing what research did you do, what did you put in as far as like ethical standards that might be matched or broken by certain decisions. Um, how are you making this decision? It's not about justifying after the fact. It's about how you got to the decision in the first place. But really, at the end of the day, it's about client autonomy. So, talking to them about what is in their record, if you aren't already, start talking to them about that, about the confidentiality of that information, where the information could end up, how it could end up in these databases. So, I'll go back to that quote about electronic health record data with participating institutions. I found within the NIH information, like where do they pull their data from? There is a database under the National Center for Advancing Translational Services. And then the N3C is more specifically what they are using. They have a list of all the participating institutions that provide their EHR data to be aggregated and included in that database. Slightly surprised, but also not, that two of the institutions where I have received medical care were on that list. So here in North Carolina, it is the Duke School of Medicine, and then the UNC Chapel Hill and their institutes of health, their healthcare system, rather. So I have used both of those, and that likely means that my information potentially was included in that data. The reason for the N3C was to track. It really got started and utilized with COVID. And I know that I experienced some of the long haul COVID symptoms. So, no doubt that my data is likely to be in that database because I used a participating institution to treat that. And that speaks to some of our clients who may be using Medicare or Medicaid. Those institutions frequently do. So there's going to be an overlap of maybe a higher frequency of clients that are using those institutions than we might otherwise realize. Many of them are through universities, which are also typically research oriented. So that makes a big difference as well. They may have NIH grants. I'm not sure if this is true, but I could see where it might be true that if they receive certain NIH grants, they might have been required to participate in that database. It says it's voluntary, but if it's a grant requirement, then maybe not so much. Don't have any proof of that, but just something to tuck away. Um, Somebody mentioned in noting about diagnoses, thinking about ethical uses of other diagnoses, such as maybe a generalized anxiety disorder or major depressive disorder, if they met all the criteria except that the symptoms don't appear to be better explained by another diagnosis. And it's true that clients that we see can meet the criteria of multiple diagnoses, and that doesn't necessarily mean that in all cases we would diagnose all the diagnoses. Um, we might, if you're using insurance billing, just using one as the primary diagnosis. For me, as a licensed clinical mental health counselor under the American Counseling Association, I appreciate in our code of ethics that it specifically says we think through using diagnosis, period. Well, they're essentially noting there that a diagnosis isn't required to treat a client, that we would make the decision whether or not a diagnosis would help with the treatment of a client. And that we also work with clients on what diagnosis makes sense. I'm paraphrasing, right? But you can find that in the code of ethics. And if you really want the specific codes, I have them. I just need to pull them up. But I can appreciate the ACA's approach to that, just noting that it is a decision that we make, an ethical decision that we make to use diagnosis and which diagnosis we are using. So, yes, it is very possible that autistic clients may also meet the criteria for generalized anxiety disorder or social anxiety or depression in whatever form that might be. And so you could use that diagnosis instead. Now, that's the ethical side of it, which of course requires that decision making. There's also the legal and the billing side of that. And so there might be a question, let's say, for example, that you had been billing a client's insurance using autism as a diagnosis. And now talking to the client, y'all have both decided that it makes sense to change that diagnosis to something else. What is the reason for that? It is very possible that your insurance companies you're billing are going to want to know what is the reason or reasons for changing that diagnosis? Why the change in the treatment plan? I think that would also be important to know how you're changing the treatment plan going from one diagnosis to another. So it's not out of the question. You absolutely can. Um, Use a different diagnosis instead of autism. It's just a process to go through of whether or not that makes sense for you ethically, whether or not it makes sense for the client personally, and then together how you would navigate that if you are using insurance, whether that's in network or out of network, providing super bills. So definitely something to consider and consult with others as well. What are they doing? Do they see this to be accurate as well? I mean, to just go along with the ACA code of ethics, someone could technically have anxiety. They might meet the criteria of generalized anxiety disorder, but it might not be appropriate to diagnose them with that for any variety of reasons. So there's always room there for an ethical decision. It's not, again, a clear yes or no just because someone meets the criteria. Do you diagnose it? There's no clear answer there. For folks who are doing assessments, this is an area of maybe looking at other diagnoses that could be included with autism. If the clients may be choosing not to involve insurance at all, make sure that if you're in network with insurance, you have them sign something noting that they're not using their insurance. That is a provider by provider decision, and there are guidelines out there on how to do that. But definitely something to consider if you have clients requesting not to use insurance. If you're in network, what does that mean for your contract? What would you be required to have the client sign or acknowledge so that you can do that? Those are above my pay grade today on a free YouTube live, but it is definitely something that is talked about by mental health professionals. So there are resources out there on what to do and how to do that for sure. Yeah. I'll keep talking because I have more. I can keep talking, but if you have questions or concerns, feel free to put that in the chat. Or if you don't feel like subscribing, you can email it to us. The email is down in the description below. It is admin@ccresourcing.us, and I can put that in the chat as well. So there's some other folks who are talking about this. It's not just me, obviously. I think a lot of you are talking about it. But if you're looking for suggestions, another YouTube channel that might be helpful is Mom on the Spectrum. She has posted several videos recently tracking the news around this potential autism registry or platform. She's made some great recommendations, some of which I've already talked about, but that I will just reiterate. So she notes for folks to check their devices and turn off any syncing or data sharing that might have already been turned on, or opt out of it in any way that you can. She recommends that client ask how their data is being shared by all of their providers. And here I'm going to stress that this includes pharmacies. Pharmacy data was noted by Dr. Bhattacharya in the list of places that data could get pulled from. So, how is our data being compiled by our pharmacies and how is it being shared? Don't just ask, what you think of with your medical providers like your mental health provider, your PCP, primary care provider, maybe some of the specialists that you see, like a neurologist. Also, think about any of the places that your data goes, like a pharmacy. And she also notes asking if the data is specifically shared for research, and if so, can the data be limited and or just not shared at all for research purposes? So it does make me think through those institutions that I mentioned and where I'm receiving care and maybe asking them, how is my data shared with regards to research, since I know they're on that list. She also mentions reaching out to senators, representatives, and other advocacy organizations, asking them what do they know about this, what can we do, what can they do, just essentially advocating for yourself and expressing your concerns. Thankfully, she provides several templates for reaching out to them, so you could use this to copy and paste for an email. Many of our senators and representatives actually use a contact form on their website, so you could plug it in there, or with one of the advocacy organizations she mentions is the Autistic Self-Advocacy Network, and she provides their main email address and some wording that you could email them. Now, the Autistic Self-Advocacy Network has already made several posts on their website about everything that's going on as well with the potential for a registry or a platform. They keep it updated with any changes that they are made aware of, and they also note things that we can do as both providers and patients to protect our data. There was a question about RFK Jr.'s claim that they'll find the cause, so non-genetic, and treatment for autism, and how that might impact our treatment. Yeah, this is a great question, and I think any potential like research that would be finalized is still years off, and even after that, it can take 9 months to over a year for research to actually get published. So we're looking at, I don't know, three. This is Dana's opinion and estimate, having done some research, that we might be looking at 3 to 5 years at the earliest that we'd see the first publications from this. I know that they really want to push it through. It sounds like they might be creating or using their own peer-reviewed journal of sorts so that they can eliminate some of the time restrictions that are usually put on peer-reviewed research. So it may be that they can get it done quicker, but it's going to take a while for them to compile data and for any research to come out about it. So, how might this impact us as mental health providers? Well, first, I think that it would have to affect our diagnostic manual, so the DSM. Um, it is used only, the DSM is only used here in the United States of America. It is not used anywhere else in the world. The rest of the world uses the ICD. That's a different discussion for a different day, but it would really have to affect how or if autism is located in the DSM. And even though the DSM, there are many years between the different versions, the APA, American Psychiatric Association, who puts out the DSM, they do provide updates every like September, October of every year. So there is the potential for them, if let's say that they found some of the information from the research enough to make changes to the DSM, then they might do that. Um, so that would change maybe the potential for us to diagnose or use that diagnosis for treatment within our profession because of that DSM. But otherwise, I think it comes back to just treating the client. The effects, if you will, of autism, like how autism shows up, how autistic people are, like none of that's going to change just because a paper is published, right? Um, Difficulties with executive functioning, that's not going to change. Anybody's relationship dynamics, that's not going to change. What we do as mental health professionals, I don't think that that's going to change how we approach clients and the concerns that they bring to us, just because the potential cause is changed. It There is the I guess the chance that they could affect the treatments that we could use, so to speak, for autism, but I don't know. I think that would be a reach, an overstep on our profession to change how we're already using the tools and techniques and theories that we already have. So, what might actually happen is some additional treatments are proposed for autism, and that's not too different from what we've had in the past, right? With a misunderstanding of even just mental health in general, but just how treatments have changed over time. It's possible they will recommend additional or different treatments. So that's going to be their research conclusions. That might be their suggestions from the research. But I think again, for us as mental health professionals, I don't know that this will change too much of how we actually are working with autistic clients. So I don't know if that answered your question. It kind of isn't that like clear yes or no, but it's just a general kind of Dana's opinion on how this might affect the way that autism is viewed in general as like a medical model. But I don't think that it changes us as mental health professionals and how we have that relational connection with clients and how we use our tools, techniques, and theories that we have at our disposal. So hopefully that answered your question. If you're thinking, yes, okay, yeah, your worry is the ABA might be the only approved treatment. And I think too, in some states, it is considered the only billable treatment to a certain extent. So there's already some truth to that, right? As ABA treating autism. I think again that's what's different for what we do, where we're actually working with folks on their relationships and going to work or to school, or just their confidence, their self-esteem, their self-talk. Um, I think if we are using it in a mental health space, I don't think that that will change too much because we're not really treating like autism. We're treating whatever life stressors that they have going on, which, having a neurodivergent affirming lens for that is always going to be really helpful. But I think at our core, most of us are not trying to treat the autism, so to speak. So I think ABA being the only approved treatment right now, there's a little bit of truth in that because many people see that as like a gold standard of sorts, or potentially the only thing that's being reimbursed by certain insurances. But for our mental health approach for things, I think our theories, our techniques, our everything that we're using is still gonna stay available to us to work with autistic clients. So that was my clunky answer to your very well worded statement there on your concerns about ABA. Yeah. Yeah. I don't think it's outside the realm of concerns. Okay. Let's see. So somebody sent in an email asking, and if you have more questions about ABA and treatment and everything, please put it in the chat. I will come back to it. I just saw this email come in. Questions around the um, privacy for Zoom and telehealth, including HIPAA compliant Zoom Pro version. Um, so Zoom does have a healthcare version, so to speak, which really is the same as Zoom. It is what it is, but you have a like a business associate agreement with Zoom, just noting how the health information, which is our sessions, is being shared over the Zoom platform. So truly the security and compliance with HIPAA, they're different things. And a lot of it has to do with how we are using the platform. So the platform may say, like, hey, we are meeting these standards of HIPAA, but then your obligations are this. And actually, Google and their workspace has a really straightforward checklist of like, here's our obligations under HIPAA, here's your obligations under HIPAA, and this is how we make our platform secure. So with Zoom, that's something to just keep in mind, that essentially it's the same Zoom that everyone else is using for the most part. There's not too much that's different about it other than you're signing a BAA or business associate agreement with Zoom to send and receive health information over Zoom. Um, just you went on to note that you use an EHR, you don't use an EHR specifically due to privacy concerns, and that recently you become more concerned about Zoom, even with the BAA agreement and the supposed HIPAA compliant protections. So, how do we learn about their potential for sharing information, especially if it becomes required at some point by the administration? So Zoom should have in their privacy policies, just like any EHR, how information is stored and how it is shared, whether that is locally within your account or on a more global aggregate scale. I will give you a personal decision that we made at my practice regarding Zoom when they made some recent changes to their privacy policies. It's within the last couple of years. It's not as recent, maybe probably 2023, maybe early 2024, where it was regarding the cloud and how, and this is very, very like, I drilled down, and this is one thing that I'm talking about with their changes, recordings that are on the cloud. So in my practice, I will often have student interns, student clinicians, and I require them to record their sessions. So they could record it in Zoom and it could be stored in the cloud. And depending upon how much I want to pay, it could be stored there for a long time. The problem was that Zoom was essentially indicating that they would use, or there's the potential for them, not that they were, but there was the potential for them to use recordings in the cloud to put it into their AI processing. And it wasn't really clear like how they're going to do that. They have added a lot of different AI components to Zoom, and this was one that I found regarding the way they were going to be using recordings, that I found very concerning, because if you have a recording on their cloud, obviously you've got the client's face, potentially their voice, you've got the chats that are in there, and then the provider as well. Anything that they're saying or doing is going to be recorded and then kept in the cloud and then potentially put through Zoom's AI system. So our decision at our practice was not to store any recordings in the cloud. Zoom came out pretty quickly after. We were very good at this after we pushed back as health professionals and said, wait a second, we're using this platform because it's supposed to be secure. And you're now saying that our content might be put through this AI system. And they didn't really roll back what they said they were going to do for recordings. They just kind of said, oh no, if you have the healthcare version, don't worry, we won't do that to you. But they never changed the original wording in the privacy policy. And if you know me, I am a rule following, detail oriented person. So I reached out multiple times to multiple different people at Zoom to say, okay, you've not clarified this. Will you be using these recordings in your AI processing or whatever? And they never gave me a direct yes or no. So that's why I made the decision not to keep any of our recordings on the cloud. And that is going to be the case with anything. So you say you don't have an EHR. If you're not doing paper copies of notes, if you're storing them anywhere, such as a Microsoft OneDrive or Teams, or if you're saving it in the Google Workspace Drive, just make sure that whatever platform you're using, you're aware of what the security limitations are on any of that data in there. There's a potential for it to change at any time, like it did when Zoom updated their policies, and the same goes for anywhere else that we might be storing information. So hopefully that is helpful in answering that question. Um, Somebody mentioned the ethical decision making template, so I will pull that up and share it with y'all. So I'll put that link here. So that will take you to, or it should anyway, let me know if it doesn't. It'll take you to the ethical decision making note template. And so that breaks down. I've combined, if you take the actual training, you'll see I've combined two different ethical decision making models, one that is created by some folks with the ACA, American Counseling Association, and some folks with the social work and social work. I don't know if it was through an association, but it was specifically written by social workers. So I combined those two into my own version of ethical decision making note because I liked certain elements of each of those that I think made the process really thorough, made it very straightforward and easy to record. So, a question, if I'm considering not using an EHR and going back to paper or locally stored electronic charts. I have considered that, and I have done that in the past when I worked with an institution who was not on the list, by the way, and I do still receive some of my medical care there. They were not on the list of those who were contributing to that database, but all the medical providers use the same EHR. So, Epic, if you've ever used that, um, it was a pain when I used it, and I don't know that it's improved very much, but it's typically used for very large scale institution like work. Um, and our mental health records were supposed to be more secure than the rest. But all that meant was that you basically had to put your name in if you were going to go in and view the mental health records of a client or a patient. So, for example, I'm in there, I see multiple providers through this institution. Let's say I also see my therapist and or psychiatrist at this institution. So if my neurologist was at this institution and maybe saw that I was seeing a therapist and a psychiatrist and was like, I want to see what those records are. When they went in to see them, there was no true block on that. All they had to do was note, like, I'm Dr. So and so. And then they were into the records. So um, when I worked there, I worked with a lot of trans and non-binary clients who were concerned because this was a very small town, a very rural area of my state, and they knew some of the other people that worked in the institution. This is not uncommon in that area, that people would know people and overlap. So there were some concerns about, what if this person that I know works at this institute was like one day, oh, I'm interested to see what their mental health records say. So I made the choice at that time to have paper copies of records. We had a really large file system that was lockable, it was waterproof, it was fireproof. It's all things to consider if you have paper only. And so I would type up my notes in a Word document and then print them and then make sure that anything I had written on the computer was deleted. So that was how I decided to keep those. Back then, all of our intake paperwork was on paper. I was meeting people in person. So it was a lot easier to just do everything on paper. Now, everything I do is online. So it would be a lot harder, not impossible, but a lot harder to send clients all of my intake paperwork, uh, print it out, package it up, mail it to them, have them fill it out, and then I guess what like have them mail it back to me, so that it wouldn't get into any system. Um, I am opting not to do that. I chose an EHR that I felt had pretty high privacy protections. I felt pretty confident with them. Um, they have very clear, concise privacy protections in their policy. So that made me feel more confident about that. And it also helps with executive functioning of clients because of the different logic models I can put into the questions. Like, so for example, if they said no on a question, it would take them to the next one. But if they said yes, it would then open up a block for them to describe whatever they said yes to. I really like the way the consent forms are set up in there, and I'm constantly adjusting it and trying to improve it. And I've had really good feedback from clients. So that's why I chose that EHR. That's why I've chosen to stay with that EHR as much as I have looked at others. This one to me feels the most secure for the ones I've actually tried out. Um, it would just be it would be a lot of work if I went back into paper or locally stored electronic charts because I would be collecting all of that upfront information in the intake with clients through paper copies, which right now don't feel very feasible to me. So that's why. Have I considered it? The answer is yes. Am I doing it? Likely no. I've just done the best I can with the protections. I put in the intake form that some of the questions are optional. So they are noted as optional. They do not have to fill it out. They can just write inside the space. I'd rather talk about this during the intake. However they want to do that is totally fine by me. Some of the questions are there because clients find them affirming, so they're in there, or I find it important for my work. But at the same time, I recognize that clients may not want to answer those ahead of time and put that in their file. They may just want to talk to me about that in the session. And it doesn't mean that I necessarily have to write down, word by word, verbatim what they're saying or anything like that in their file. There are different ways that I can be broad, but yet have enough information. So it's doable. It's definitely doable. But I don't think for me right now that I'm going to do that. Yeah. And that is something to consider for those of you who are doing paper or locally stored. So maybe putting it on like an external hard drive, putting it on a USB. They can hold a lot more than they used to. So those are options, but what computer system are you using? So Windows, the new version, has Copilot on it. This is an AI system. I have pretty much turned off anything that I don't have like on my phone where you can do the voice to text and stuff like that. I have the microphone turned off. So it's not listening to me all the time, waiting for me to say its name and wake up. If I have a program that is using AI, I turn it off. So on my computers and things, I turn off the Copilot on Microsoft. I'm sure there are Apple versions as well. Any of the platforms I'm using, like Zoom, I'm looking into how is information being disseminated, even if it's used within Zoom with their AI, and making sure that I turn off as many of those as I can so that it's not going to store it unless I want it to. Um, so that was a long, long answer to your question, but hopefully that gives y'all some insights into decisions you might make around electronic healthcare records and paper notes and things like that. And that does lead into progress notes. So that's a question that I'm often asked, like, what should we be putting in progress notes? You will not be surprised to know that I have a progress note template and training. But I think it's important to think about who is going to be receiving the notes potentially, Like if someone just picked them up off the ground, would they know what you were talking about? Um, if they got released somewhere, would the person know on the other end like exactly what you're talking about? So we have a lot of restrictions or in my practice around what we do and don't include. I'll just give one example. So let's say my mom, who I'm pretty sure has left at this point, if she and I had a fight, then my therapist, if they're at my practice, would not put in that I had had a fight with my mom or that my mom had said such and such a thing. Instead, they would note something about it, interpersonal conflict or something like that. So those are ways to write in progress notes what is actually going on, what is therapeutically relevant without putting in any details or pulling in other people that might not necessarily need to be in there. If we're talking about concerns over the autism platform or registry, maybe just noting that as like social justice concerns, confidentiality or privacy concerns, things along those lines that maybe don't note that registry specifically in your notes. And I think others I often hear, well, I just write psychotherapy notes. I don't do progress notes. And psychotherapy notes actually are more about what's not in it than what's in it. So HIPAA will tell you exactly what, if it is included in a note, it is automatically a progress note. So psychotherapy notes have very, very, very little information in them. They can't include session date or start or end times, diagnoses, things like that. So if you're trying to get around noting autism in a progress note, don't put it in what you think is a psychotherapy note. If taken to court, it likely would be considered a progress note. So just keep that in mind. Progress notes are definitely for you. They are also for the client. So what if your client read that note? Then what might they think? If you have a request for records or a request for data from your clients, what options do you have? Think about who's requesting it, why they're requesting it, and what exactly they want, and ask that same question. So if your insurance company reaches out to you and says, "Hey, we're doing an audit and we need all of the complete medical file for all of these clients who fall under this diagnosis," ask them, go back and ask them. So, what is this audit for? What is the audit being used for? In lieu of sending you the complete medical records, what could I send you? Could I send you? And always refer back to uh, the HIPAA and look at what they note as far as de-identifying information. Absolutely. If anybody needs to leave, you're welcome to. I'm going to hang out here. I did not have an end time. So I will be here. I'm checking email for any questions that might come in. So I've got that pulled up. I have resources I can plug in. This will be recorded. My hope is to get it out ASAP. If it's looks good enough, then maybe I won't need to do any editing. But if it needs some editing, I'll do that and repost it with the intention of hopefully offering it for CEs as an on demand in case you didn't meet it live today. Yeah, of course. If y'all, like I said, I will be here. So if you have anything any last questions, thoughts, concerns, plug those in even before you go. And I will be sure to answer those here while the recording is going. Or if you think of something later, come back and put it in the comments, and I'll be happy to respond to your comment, or send me an email, and I'll be happy to email you there as well. But I'll hang around in case you have questions, or if you want me to just keep talking on about some of the other things I wrote down, and that I think about on a daily basis. Appreciate y'all being here, spending your time. The dreaded silence. So if you haven't checked it out, I have a training. It's an hour and a half. It's the clinical and ethical considerations in diagnosis, note writing, and record keeping for trans non-binary clients. That training goes over all those areas related to trans and non-binary clients, but it is very applicable to what we're talking about today. Many of the things that I mentioned are also mentioned in there. Oh, and then maybe we were reading each other's mind. So the comment here, any thoughts about the intersectionality of autism and gender incongruence? So maybe trans, non-binary folks. I'm guessing those folks are probably even more concerned right now. Absolutely. And I think for trans and non binary folks, this has been top of mind. So some of these same things have already been talked about. I think the Vanderbilt University Medical Center is a great example. It is not that long ago, 2022, that happened. And it definitely caused many of us to start to look into our practices to see how can we be and do better. So a lot of what we might be doing for trans and non-binary clients can definitely apply for autistic clients. And then, of course, the high overlap. So autistic, trans, and non-binary clients. Just being really minimal about what we put in notes as far as details are concerned. If there is maybe exploration around gender, just putting identity exploration as a topic instead. Um, Considering again, where does that information go? So, are you helping clients with gender affirming care? Are you writing letters, things along those lines? That overlap has been top of mind for a while. For example, would having an autism diagnosis negate someone from being able to access gender affirming care? Maybe. I think there have been cases of that. Definitely cases of mental health concerns that were noted to be too much for someone to access gender affirming care. So already that overlap has definitely been there for a while, and is something for us to be just talking to clients. Do you want this information on your file? You have an option to put your pronouns. Do you want your pronouns on your file? You have the option to use a name other than your legal name. Do you want that on your file? If I haven't mentioned it already, I really recommend creating a test client in your EHR if that's what you're using, and create progress notes, create a treatment plan, create diagnosis, all of those things. Do the intake paperwork just like you would. I do this just because I want to see how well my system's working and what I can do to improve. But go ahead and fill that out as a client would, and then once you've got all that data together in that fake client's file, then test out a complete download of their medical record. What is included? What might you need to do if you were ever required to submit information or requested to submit complete medical records? What would that look like if you just downloaded it and handed it over, or printed it all off and handed it over? What does that look like? So give yourself an opportunity to know ahead of time before you get requested, which hopefully you never will. But at least this way you'll be more prepared in case that does happen. So that might have answered your question. I just think that for trans and non-binary folks, we've already been on high alert around this. So we've already been kind of paying attention to how our records are being used, what's included in our records. Something even to consider that some of the providers I've used will require some sort of identification, so a driver's license or something like that. And I even had one place that wanted like the front and the back of the driver's license. Okay. So now you got that in the file. Does that get downloaded? Does that get handed over? Does this person or entity on the other end now have a copy of my driver's license? So if you are requiring that as a part of your intake, to what extent are you using that? That's fine. If you, yeah, right. So mention there, never been a pause with concern about records as trans and non-binary folks. Yeah, and the concern around that, goes up and goes down, but it's always there and it's always a consideration. So definitely recommend, if you haven't checked out that training, that would be one to check out. I have um, an option where you can ask me anything as a part of it. So I'll put that in the chat as a link. So you can actually send me messages and ask me specific questions that you have. You can just buy the course. Like, don't feel like you have to do the ask me anything. But if you wanted to, you'd have access to me live, so to speak. So you could ask like, "Hey, this is going on," or "have this question," or whatever, and I could provide some insights into that. Not a lawyer, even though sometimes I sound like it. I'm not like a biller or credentialer or anything like that. And I'm not a CPA. So, all those aspects of business, definitely recommend getting that outside help with that. Consult with other providers. What are they doing? Get a supervisor, someone to look over your information. Even if you're fully licensed, find someone to look over what you're doing, to test it out as a client on their end and give you feedback on that. Talk to your malpractice insurance, whatever your liability company is, ask them about it. Talk to your associations and ask them what could be done and what is being done. I think we're going to see a big push for associations to do something, to say something. We're only 1 week out from when this was announced. So many organizations I've worked in, for profit and nonprofit, been on boards. And as a board member, we want to make sure we do it right. So if you're like, what is taking so long? Many of them are probably consulting with lawyers, PR experts, all of that to figure out like what's the best way to respond to this. Not to mention it's pretty much changing every day. So it's hard to respond to something when it's different every day. But if you are upset about them not responding, that is likely why. They are probably all together working on this almost nonstop, trying to find the best way to respond to this. That was a bit of a tangent, a soapbox, if you will, but hopefully that was helpful as well, as we are all concerned and all want more to happen and change. I just want to emphasize, if you weren't here at the beginning, that there's been no formal statement from HHS or NIH noting that the registry or platform will not be created. Those were statements made to multiple journalists who then publish those statements in their reporting, but it has not specifically been stated by NIH or HHS that they will not be creating this platform or registry. We know that there are other registries or platforms, as they call them, already out there with de identified aggregate data. The concern with this one is that you would be able to identify specific individuals, and that concern is not unfounded. So that's why we're talking about that today. Any other questions that you might have? Like I said, I will hang out until the last person leaves. I will be here and happy to answer questions, address concerns, put it in the chat, put in the chat later, comment it later, and I'll be sure to follow up with y'all. But I just want to get this out here quickly so you could have some insights into what's happening and what you could potentially do about it. Because that's what our question is, right? Like, what can we do? I can put some of the other resources that I mentioned. So here is Mom on the Spectrum. That is her YouTube channel. And then let's see, I must have closed it. This is the Autistic Self-Advocacy Network. So when you go to their main page, right at the top, you can see the where they talk about walking back the plans. They talk about joint statement, things along those lines. Oh, thank you so much. So Fortune and I are actually from the same state. So that's probably why our accents are very similar. Uh, yeah, I appreciate your kind words. If there's any other resources I can send, let me know. Mom on the Spectrum does have in the description on some of the videos that what the language you could use to reach out to senators, representatives, stuff like that. So don't hesitate to go watch her videos, use the language that she has. Note that she pretty much updates almost like daily on what's going on. So some of the more recent videos may have more recent information. All right. Well, I think that's about it for us. I'm going to go ahead in the stream, and do not hesitate for those of you who maybe join us later, watch this on demand later, to email me any questions or concerns that you have. Put them in the comments. I will be looking out for that so I can reply as I'm able. And then the hope here is that I can include this as an on demand training. So that's a long term hope. I appreciate everyone who came today, all of your questions and concerns that you asked. But don't hesitate to keep sending them because there's going to be more. It's continually changing, right? So thank you again. Thanks for being here. Thanks for supporting your clients. And I will talk to all of y'all soon. Thanks.